Okay, and our last speaker in this session is Stephen Williams from MD Anderson, who is going to be talking about provider relationships and the diffusion of new technologies.
Good afternoon, members and guests of the Institute of Medicine. Thank you for inviting me to speak here today on provider ownership and the diffusion of new technologies. A brief introduction of myself. I finished my training at Brigham and Women's in the Harvard program, urology, and subsequently entered private practice for a couple of years, and then decided to take a vow of poverty and enter urologic oncology fellowship at MD Anderson. However, I've been very fortunate to continue my prior health services research with some of the members here today, and I look forward to presenting our data as well. The brief outline will include a review of the Stark Law, and then unfortunately, or fortunate, we're going to discuss more about urology, particularly as a model system for provider ownership, and then subsequently provider ownership and utilization of imaging and pathology in urology, followed by provider ownership and utilization of radiotherapy in urology. This is a conceptual framework, which I also have to acknowledge Dr. Ben Smith, who helped also formulate these slides, and we came up with this together. Here we have a provider, which may or may not have arrangements either in imaging, medical oncologist, pathologist, or pathology services, and radiation oncologist, all of which may influence the management and care of our patient. The Stark Law itself, under federal law, it's generally illegal for a physician to refer Medicare or Medicaid patients for designated health services in which the physician has a financial interest. The federal law, also known as Stark II, prohibits many physician self-referral arrangements. This was enacted by Congress in 1993 to address many of the shortcomings of the federal anti-kickback statute. Under that statute, criminal, civil, or administrative liability can result if one knowingly or willfully offers to pay for, solicit, or receive any remuneration to induce referral of items or services reimbursable under federal health programs. There are several exemptions, however, that do exist. Physician group practices are exempt for in-office ancillary services if the group practice meets specific criteria. And the second of which, as has been previously alluded to, physicians may self-refer if the services are personally performed or supervised by another physician in the same group practice. This does not apply to specific types of facilities, in particular ambulatory care surgical centers and so-called whole hospitals. There are several pros and cons that are associated with provider ownership. Some of the pros include improved access to care and dissemination of advanced technologies and services, the so-called one-stop shop. And this includes also to improved patient convenience and access and satisfaction. Moreover, as has been discussed by Dr. Hu, as well as in regards to volume outcomes, have also been associated with or may translate into superior outcomes as it relates to provider ownership and access to these services. There are several cons also too that do exist. The potential for financially rather than clinically appropriate decision making, and then also too potential for overutilization of expensive technologies and increase in healthcare spending. As I mentioned before, urology serves as a model system for provider ownership and how to analyze this. I received this brochure from the American Urologic Association a couple months back in regards for their AUA annual census in 2014 discerning American Urologic Association members as well as their practice patterns. What was interestingly to note here is there's practicing urologists employing other services and providers range widely from laboratory services, a little under than 50%, to a radiation oncologist, which is a little over 20%. And actual ownership in medical services and equipment range from pathology services to a little below 18%, to IMRT, a little above 12%. So going back to this conceptual framework that I initially presented, I'll discuss briefly how it relates to specifically imaging and provider ownership and translating to patient care and management. Using Dr. Mitchell's study here, she specifically looked at the prevalence of physician self-referral arrangements after STAR 2 law, and particularly in California in regards for advanced diagnostic imaging. What is depicted here is that among the self-referral urologists, roughly about a third are involved in some form of a self-referral arrangement for the various imaging modalities depicted here. What this diagram represents is that 61 and 64% of those who have self-referral arrangements for MRI and CT scanners respectively may in fact be in violation of the Stark law, as they do not have actual ownership but have a lease, timeshare, or pay-per-click model arrangement. The second point of discussion, which I'll discuss briefly, is the utilization of pathology services in urology and how it's influenced by provider ownership. And this study by Mitchell as well, she looked at urologist self-referral patterns for pathology of biopsy, prostate biopsy specimens, and how that was linked to increased use and coincidentally lower prostate cancer detection. In this study, and to discuss this briefly, a urologist normally obtains a 12-core biopsy, and in that 12-core biopsy, either from the left and the right side, the cores itself from the apical to the base are placed into 6 separate jars, which is currently guideline based. Urologists may also place each of those cores in each separate jar, which could be billed for their professional services separately. And this translates to doubling the reimbursement that you may obtain per prostate biopsy. What she was able to find here is that there was a significant increase in the mean number of pathology biopsy specimens, that's jars, per prostate biopsy submitted upon self-referral status. What was interestingly to note as well is that there was actually a decrease in the percentage of biopsies with a positive prostate cancer diagnosis by self-referral status. The last point of discussion, which we'll mention today, is provider ownership in regards to radiation oncology services, and particularly IMRT. In this landmark study by Dr. Mitchell, she specifically looked at urologists' use of IMRT for prostate cancer and the association for provider ownership and utilization of IMRT, utilizing Medicare claims from 2005 to 2010. She looked at 35 self-referring, 35 non-self-referring, and 11 non-self-referring urology groups, and compared utilization of IMRT both before and during the ownership periods. What was identified here in the pre-ownership period is that the utilization of IMRT was approximately 13% for both groups. And this remained somewhat consistent upon the ownership period analysis for those self-referring urologists. However, what is obvious to see here is there was roughly 17.9% increase in utilization of IMRT upon for the self-referring urologist during the ownership period. This is a busy slide depicting the various treatment options during both the pre-ownership period and after the ownership period for self-referring and non-self-referring urologists. I broke this down by an actual bar graph, which I think is easier to see, and as we pointed out, the increased utilization of IMRT and the post-self-referring urologists. However, what's interesting to note here as well is that for the brachytherapy, there's a significantly decreased utilization in brachytherapy being one of the more cost-effective means for radiotherapy for particular types of prostate cancer. This translated to a logistic regression marginal effect of 16.9 percentage points among those in a self-referring arrangement, which translates to an odds ratio of 2.79. So in conclusion from that study, and her conclusion was referral by urologists to IMRT services in which they have a financial interest is associated with increased use of IMRT. However, with all studies, there are some limitations, which are noted here, in a lack of tumor characteristics and risk stratification, of which Dr. Miller mentioned briefly in his discussion, and are important when discerning appropriate utilization of treatments. There's a lack of physician characteristics and perceptions of profitability. And what we've also noticed here through this workshop is that radiotherapy is being commonly utilized and may be, in fact, a preferred treatment for many of our patients. Now, what I am involved with over at MD Anderson, I'm currently a comparative effectiveness research on cancer in Texas scholar. And combining this with Dr. Hoffman, who is actually a primary investigator under the auspices of CERCIT with the Cancer Prevention Research Institute of Texas, we're able to actually perform a study of which we look at urologist practice patterns in regards for utilization of treatments for cancer, which include IMRT, according to risk stratification of prostate cancer. The data source includes a linked cancer registry Medicare data from 2004 to 2009. We included 17,982 men with non-metastatic prostate cancer. And we were able to determine the diagnosing urologist using claims data. In a previously published manuscript, we were able to identify 13 integrated urology practices. The primary objective of this study is to determine how urologist ownership interest influenced decision to treat or not treat prostate cancer, and also determine if this varied by patient group. What we're noted is that over the study period, there's a significant increased trend of patients being diagnosed and managed among integrated urology practices. Moreover, when looking at favorable risk prostate cancer patients, of which active surveillance is a guideline recommendation, there was an increased utilization of treatment with IMRT more commonly utilized among integrated practice for favorable risk patients, which translated to an odds ratio of 1.45. What was interestingly to notice as well is that among unfavorable risk patients, of which active treatment for prostate cancer is a recommendation, there was an increased utilization of treatment with IMRT more commonly used among integrated practices as well. And this translated to an odds ratio of 1.53. The manuscript, the data that I previously presented, the manuscript's currently in preparation for publication. So the overall summary for provider ownership is that prior research have shown varying practice patterns according to provider ownership. With radiotherapy in particular, IMRT are being increasingly utilized in urology for the treatment of prostate cancer. Prior research have demonstrated increased utilization of IMRT for the treatment of prostate cancer according to self-referral practice patterns. With provider ownership may result in varying utilization patterns of IMRT for the treatment of prostate cancer, which is independent of tumor biology. The next couple of slides describe some sample patients, and the patient that we have here under the current paradigm, a favorable risk prostate cancer patient, has an increased likelihood of being referred to a radiation oncologist. And under the current data that we have at present with among integrated practices may result in inappropriate utilization of radiotherapy, which translates into a bad outcome. However, among unfavorable risk prostate cancer patients, of which treatment is in fact recommended, there is integrated practices have an appropriate utilization of radiotherapy, which translates into a good outcome. However, as we stand right here today, there is a need for health policy reform to guide appropriate utilization so that we can optimize the treatment and care of our patients. I'd like to thank these individuals for supporting me and allowing me the opportunity to present our data here today, and particularly Drs. Hoffman and Smith for allowing me to work with them and present our data. Thank you very much.